Good afternoon, everybody. So today my topic is whether we should go in for a comprehensive training and or we should go in for a fellowship, and if fellowship, then what fellowship to choose. I am Dr. Supriya Arora, Senior Resident in Retina Services in Guru Nanak Eye Center. So the question is that I have finished my PG. Now what to do further? Should I go in for a comprehensive training or a fellowship, or a comprehensive training followed by fellowship, and which specialty to take? So what we need to assess is that what is our interest in this, what are our future plans, and what is the level of our training in PG, medically as well as surgically. We need to realistically realize this. What is comprehensive training? It means that in medical ophthalmology you should be able to diagnose and treat most of the conditions, and as far as surgical ophthalmology is concerned, you should be confident in cataract, be able to do basic procedures like a lesion, incision and drainage, emergency surgeries like corneal and sterile perforation repair, laceration repair and foreign body removal from AC, otherwise simple oculoplasty like entropion, ectropion and DCR, simple horizontal muscle recession and resection, and trabeculectomy. This is as per MCI guidelines. Now, after passing out PG, we need to realize what is the level of our confidence. Is it low? That means you've not adequately been exposed to all subspecialties and cannot confidently make all diagnoses, cannot do cataract surgeries confidently. Then there is absolutely no question for you. You need to go in for a comprehensive training. The other thing is that your level of training is medium. You are exposed to all subspecialties, can make diagnosis, have performed enough cataract surgeries and can perform it independently with a low complication rate. Then this question is relevant for you whether you should go in for a comprehensive training or a fellowship. And if your level of confidence is high, then you really need to reassess yourself. Then you have to decide what are your future plans and how do you want your lifestyle to be. Where do you want to settle? Whether you want to settle in a small place, village, a district or a metropolitan. The type of practice that you want to be in a government setup, you want to be in an academic institution or any other government job, or you want to do a private practice. In private practice, you have to decide whether you want to be a lone practitioner, you want to do a group practice, or you want to join one of the corporate hospitals. If you want to go to your hometown, which may be a district, and establish your private practice there, then comprehensive training is a very good idea. If you want to stay in a metropolitan, then there are three options that you have. If you decide to be a lone practitioner, then comprehensive followed by a fellowship would be a good idea. In a group practice, fellowships can work well, but it is always better to be self-dependent. Probably a small comprehensive followed by a fellowship would be good. And if you want to join one of the corporate hospitals, fellowships work well. Now, why is it important to have a comprehensive training before fellowship? You took up the patient for a multifocal IOL, and the patient was a case of heel central serous chorioretinopathy with a subfoveal PET, now complaining of severe metamorphopsia. A 55-year-old patient with 6/18 vision and grade 2 cataract. We just did a simple cataract surgery, went well, but missed the subtle ERM. Now patient's vision does not improve and is, always complaining. You're doing a buckling surgery and a balsa muscle. If you know the basic principles of a squint surgery, you sort it. You failed to diagnose pubes endothelial dystrophy in a patient and went ahead with a cataract surgery, and the patient lands up with a PBK. You're a refractive surgeon and a lone private practitioner, and you missed a break while doing a peripheral screening, and the patient lands up with an RD. This was one of the case reports recently published. Basically, the authors missed subfoveal lacquer crack and a pre-existing neovascularization, myopic CNVM, and the patient landed up with subfoveal hemorrhage 4 days after the surgery. The vision never came back to normal even after 6 months. So this is the lesson that fundus has to be very, very carefully screened before going in for any kind of refractive surgery. With a comprehensive training, you're much better equipped to handle intraoperative complications and postoperative complications. It is important for your convenience as well as the patient's convenience. If you're a vitreoretinal surgeon, you can't always depend on an anterior segment surgeon for doing your cataracts. Say you want to plan a patient for a phaco plus SOR or a combined phaco-vitrectomy, it's always better that if you can do your own phaco. You may be better equipped to handle your own complications than just panic. If you cannot differentiate between a myopic disc and a glaucoma, either you prescribe lifelong anti-glaucoma medications to a myope, or you make a blunder by missing a 0.8 cup. Okay, if you're not confident, you can always refer to a glaucoma specialist. But you will realize the greatest need while dealing with your own post-operative patients. If you're in a corporate where all these subspecialties are available under one roof, it's not that much of a problem. Or even in a group practice where you have all the specialists. But if you're a lone private practitioner, then obviously you cannot keep looking at people as a substitute for these skills. Comprehensive training gives you a big cushion in life. If your specialty practice is not getting you enough patients in private practice, you can always bank on comprehensive skills till the time your specialty practice picks up so much that you do not have time to see general patients. A comprehensive training makes you self-dependent. Now, if you've decided to do a fellowship, now which specialty to choose? Often your choice is influenced by your exposure to specialties, time spent in concerned specialty, infrastructure and facilities in the institute, and your mentor. But it is important to sit down and realize what is your passion, the feasibility of job or practice, and what are your future plans. As far as surgical retina is concerned, definitely there are difficulties in learning as well as difficulties in practicing. It has a longer learning curve, longer duration of surgeries. Training facilities need to be good because it needs a good hands-on and good number of cases, and definitely someone to handle your complications in the beginning. As far as difficulties in practicing are concerned, visual outcome is not always great, and you cannot always meet patient expectations, and medical legal issues are definitely there. It's financially more demanding, and you have fewer patients initially. But it gives you immense satisfaction, and you really feel like a king, and it feels that you've really mastered the skill. Practice, once it is established, then there's no looking back. Medical retina is a safer bet, less risk taking. Medical retina specialists usually tend to work where comprehensive ophthalmologists are there. Cornea again is a very satisfying field because it's a very skillful surgery, though the learning curve is high. It is dependent on eye bank facilities and donation. This is one drawback. And training and learning is again dependent on number of corneas. Refractive surgery has a fast learning curve, is technologically driven, but is financially demanding, but at the same time is financially rewarding as well. There's a huge wow factor that comes with the patient. However, even a small error is unacceptable. As far as squint is concerned, the biggest advantage is that it is not dependent on infrastructure and sophisticated equipment. Surgically, it is simple to learn and a lesser learning curve. Planning is the main thing, and it gives instant gratifying results. Oculoplasty is like an art. Every case is new and every patient is a challenge. There's no fixed pattern and no flowcharts to follow, but it requires teamwork for advanced surgeries, and it's important to acquire training from a tertiary care referral center, otherwise your exposure will not be enough. These days a lot of focus on aesthetics. However, practicing oculoplasty private may not get enough patients. Glaucoma, the patient base is large, but the referral system is still poor in our country, and cases are usually referred in a very end stage. So better idea to do cataracts along with glaucoma practice. Thank you. At the end, I would like to say a goal without a plan is only a wish. Dream high, plan accordingly, but it's always good to have a plan B ready. Thank you.